Coffee with Coker is a healthcare business podcast from the Coker Group that focuses on solutions to help healthcare organizations effectively navigate the changing healthcare industry landscape. Welcome back to Coffee with Coker, and we're excited for another episode today. We thank everybody for listening. We are joined today by Brandt Jewell, who is a Senior Vice President at Coker, and he runs what we call our Physician Services Department. And we do a lot of different things in physician services. We're actually going through a topic that Brandt has presented on a number of different conferences and events. Recently, he actually presented at the MGMA conference, and what we're talking about is a data-driven approach to managing high-performing medical groups. That's the title of Brandt's presentation, and we're just going to go through some of the key components. This is a pretty in-depth presentation, and so we may be referencing some things. If you all are listening and you're interested in the more detailed version of this presentation and copy of the slides, feel free to reach out to us. You can reach us through the website. You can reach out to find myself or Brandt on the website and reach out to us directly. We're happy to give you guys copies of this information, because there is a lot packed into this slide deck. So I really, if you're interested in more details on this topic, I would encourage you to get a copy of that. But like I said, we're going to go through this at a somewhat of a higher level than what Brandt does when he presents on it. But before we jump into the conversation with Brandt, I just want to once again thank everybody for listening and encourage you all to follow us on the different social media platforms, and because all of our content goes out in those places, as well as joining our email list, which we distribute at least weekly, really good information that goes out on a wide range of topics related to everything that we do here at Coker and a lot of the things that we see working with our clients. So really good insights there. You can also listen to all of our podcast episodes. You can find all this information at cokergroup.com. You can find all of our podcasts as well at copywithcoker.com. So again, we encourage you to check that out if you're interested in this or any other topics that we cover. So with that, I want to jump right into the discussion with Brandt. And Brandt, thanks again for joining us. As I said just a minute ago, there's a lot packed into this, and it's really good stuff. There's a lot of really good illustrations as far as some of the things you talk about, taking a data-driven approach to managing a group. And really what we're talking about here, particularly as we've come out of the COVID crisis over the last couple of years, and groups are focused on developing strategic plans and managing an employed physician enterprise more efficiently. The data-driven approach is something that I think certainly is becoming more and more popular. Needless to say, there's a lot there. So Brandt, if you don't mind, maybe we just start out by defining, what are we talking about when you talk about a data-driven approach or data-driven culture?
Yeah, thanks, Mark. Good to be back again. And yeah, I think it means a little bit something different to everyone. And it's one thing to use data or to have data. It's another thing to have analytics, and yet another to have actionable analytics. And today, really, when we talk about developing a data-driven culture, in my mind, that's making the leap from having data and using data at some level of the organization, even to make decisions. You can make data-driven decisions, but developing a data-driven culture permeates all layers and personnel within your organization, from physicians to administrative leadership to frontline staff. And I like to see organizations focus on fewer metrics and the things that matter most to their strategic objectives. So not tracking every single metric under the sun, or not insisting upon data from all sorts of different resources be, always accurate and reported on in robust format. But let's boil it down to the things that are most aligned, the metrics that are most aligned with our strategic objectives. And then how do we take those metrics and build a culture at all levels of the organization that pursues them? And so that's a very different lift than putting together a dashboard or having good reporting. Now, if we think about using data and who uses data, it's often at an administrative level. And whether you're at a C-suite level on a medical group or practice side, Or if you're on the front lines of, a practice manager where you're responsible for a clinic location or multiple clinic locations, having data to help you prioritize is essential. And there are too many things to worry about in the myriad of practice management between staffing and physician compensation and revenue cycle, coding and compliance, strategic growth, IT systems, value-based care. Just the list goes on and on of the things that could be your priority for the day. And understanding whether you have a good handle on all of those points and have good data to support it or not, having a clear picture of how you prioritize those different areas for yourself, given your role in the organization, and then also where that overlaps and how that aligns with the organization's priorities. And it may be different at the practice manager level than the COO level, than the physician owner level as to what's important and where you spend your time. But making sure that there's transparency between those groups and having priorities straight is important, because that's where you're going to focus your time and your efforts. And you can't really prioritize, in my mind, without some concrete data and evidence as to why we've chosen these priorities. And so really the presentation and the approach that we go through with our clients when we go down this path together is, one, understanding where we're weak and where we're strong and where we have areas of opportunity. But two, how do we have an ongoing process for identifying those areas, measuring those areas, and then working towards objective outcomes in those areas. And so the more we can make it objective for our teams and our people, the better off we'll be. And there are some management tactics, there are, themes that we're trying to implement with our clients that, engage key stakeholders, and that means everyone, and taking ownership in the outcome. So an example might be, I work in the centralized call center, but I don't have any ownership of our phone abandonment rate or our denials due to incorrect patient demographics, which maybe I am responsible for gathering at the time of scheduling a patient. So having an engaged and accountable person at that level who also takes ownership of a metric or two that we know is essential to our patient access or our revenue cycle performance or whatever it is that's driving our strategic objectives as an organization can make a big difference. This also gives you the opportunity to be proactive versus reactive. So many times we use data to look back and say, how did we do? Oh, we missed again, or we had a great month. Can't explain why, but it was better than the month before. We're trending the right direction. And we really want to be using data to make proactive decisions, not to just measure how we performed in the past. Using data to make management decisions. Sometimes we use data as collateral to our decisions, but we don't necessarily develop a new site or expand a new clinic location because of our data. Or we might not make a staffing hiring decision or staffing reduction decision based on data. A lot of times that can be done with more gut feel or we'll call it organizational discussion than truly using data. And so the bigger you grow and the more you have unique operating entities, the more it's important to have data just from a parity and consistency standpoint. And so that's another way that we like to use data around objective decision making. And then lastly, kind of related to that, accountability and ownership, when you develop a data-driven culture, it really isn't just for the individual. Part of the frustration for using data, not just having data from a leadership perspective, is getting others to carry water or to move the ball down the field without leadership's involvement. And so I'll go back to my example of the call center. And it's one thing for me to know that I'm responsible for abandonment rate or for making sure I get the clean claim started by getting accurate demographic information. It's quite another for all of the employees in the centralized call center to understand that same incentive structure and know that if they're able to achieve an abandonment rate of X or a clean claim rate of Y, that everyone's eligible for compensation or incentive pay, however you can structure that within your organization, or that it's going to be part of their performance review at the end of the year and whether they get bonus pay and things like that. Then now you have a team that will sort of self-police and or coordinate on their own without an administrator, manager, et cetera, having to come down on them. And so if I see that the person next to me is not answering the phone when it's ringing, or they're answering half the calls that I'm answering, or I see that they didn't ask to verify insurance. When I hear them talking on the phone, then I'm going to call that out in real time, because they're now affecting my outcomes, my performance, my incentives. And that's when you start to have a culture that works around you. And it's not always about the manager catching things or coming through and monitoring from a seat on high. And you start to see a lot more collaboration and groups, clinical teams and front office teams sorting through their own issues together, because they know it's in their best interest and the best interest of the organization, and they all have aligned incentives. So that's a long-winded answer to what it means to have a data-driven culture, but that's really what we're trying to implement with a lot of our clients, regardless of how fancy or robust their reporting capabilities are, and their data validation is key and other things. But we're really trying to get the organization to focus on a few key areas and align all their work efforts in that direction.
Yeah, no, that's very helpful. And I'm glad you did kind of cover it that broadly, because there's a lot there, and you only kind of grazed the surface even. And so there's a lot there to kind of understand what that culture really should look like or could look like. But one of the things you said or kind of alluded to was the how many metrics are out there that could be tracked and used to different degrees, but also talked about, using data in decision making. And, you can only process so much until you get into to where the data isn't working for you. And it's kind of just, becomes too clunky or weighs you down. But talk about that and the benchmarks. And I know in your presentation, you talk a good bit about benchmarks and different indicators and what targets should be set, and then using data to help make that process. Where do the benchmarks come in that discussion?
Yeah, good question. So I always say, if you've ever given physician data, you've been told it's wrong. And a lot of times it is wrong. We work with clients big and small, with great reporting or great repositories, and there's always a question of data validation. And so when we go in and work with clients, one of our first objectives is to validate accuracy of data and to get a source of truth. And usually that's multiple sources of truth, depending on what we're there to evaluate and look at. But once we have the sources of truth and we can agree that the raw data coming out of the system is accurate, or even that we understand there's noise in this third next available data or in our no-show cancellation data, often those have some gray areas. And yet, if we agree that the reporting coming out is our source of truth, even if it's got a standard deviation of accuracy, we can use that as a baseline and measure to it as we go. And so we try not to get caught up too much on spending our time filtering data or creating manual reports, but trying to work with what we have at our fingertips and then setting a baseline. We use benchmarks directionally in all cases, but when we go in and work with a client, benchmarks are extremely helpful for us to gauge relative performance, even if the benchmark cohort isn't specifically accurate. Let's say that it's a subspecialty in a unique market in the Southwest or something like that, and they don't think a national benchmark applies to them. They're probably right. There are a lot of nuances that in the benchmark data and the reporting that may not be directly applicable to them, but still for us, we like a larger sample set. We like to understand how a group performs relative to a national average, even if that's not their best comparison point or their target. And so if we use that as an underlying point of relativity, right, we understand where we fall in the national landscape based on this national benchmark. And yet our target isn't the national median. Our target is 75% of the national median or 90% of the national median based on our unique circumstances. All of that is, we would first benchmark, then develop a unique target for each client in various areas. It might be that we can use a target for revenue cycle performance, but we can't for staffing, for, you name it. There are all sorts of different areas. And then we try to boil down to a few, 2 to 4 KPIs, key performance indicators per area that are important in both monitoring and measuring performance for this organization, and then align with what we're trying to achieve. operationally. And so if we're in high growth mode, or if we're trying to manage a lot of disparate locations, then we might have different KPIs than if we are in maintaining our independence mode, where we're trying to make sure that financial solvency is our number one priority, as opposed to growth and patient access. And so there are a number of different ways you can go with that, but ultimately we like to start with benchmarks, develop our own target from there after we've got validated data for our organization, and then pick the KPIs, just a handful per operational area, that are going to be applied to and that we're going to use to measure our success, and then to permeate throughout the organization, put them into staffing competencies, physician compensation incentives, all those types of things.
So when you talk about using benchmarks directionally, is that kind of what you were saying, as far as maybe it's not 100% perfect or scientific in all cases? There's some subjectivity to benchmarks, but you can at least use them as a baseline or even a gut check. Is that what you're talking about?
Yeah, so that's right. So as an example, we might look at a claim denial percentage, right? So we like to see 5% or less claims denied. But let's say we go into a client and they've got a 20% denial rate. Well, whether 5% is realistic for them or not, we know 20% is too much. Mm-hmm. We first need to make sure that everything in their denial percentage is truly a denial. And sometimes we find that, just the data itself is inaccurate, and that can be misrepresenting both good and bad. So there's that data validation piece. Let's make sure this is truly our denial percentage and not just the one that spits out of our billing system. And then once we have an accurate percentage, if it's 20, 18, 15, well, getting it to 5 may be best practice, but that also may not be feasible for us in the near term. So now we start to peel into denial reasons. How much of this is low-hanging fruit? How much of it is more systemic, or what we call easily preventable denials versus denials that we can't control as easily, payer guidelines, et cetera. And there usually is opportunity there, but we probably aren't going to set our target for the next year at 5% if we're currently at 20, unless we see a very clear path to getting there. So maybe it's 10% as a denial target for us initially. And then once we achieve that, we talk about getting closer to best practice. But if all we did is say it's 20% now, we got to do better, and then we get it down to 15%, we might say, hey, look, our denials have gotten better, when we're still pretty far off of what that national average or national best practice might look like. And so I think the benchmarks are important, one, to give you a sense of, again, relative performance to other organizations. The same can be said for production or some patient access metrics. But then ultimately, you're going to have to set targets based on where you stand today and what's realistic. Similarly, if denial percentages target is 5% and you're already at 3%, then it doesn't mean that we don't have opportunity with denials, but it's good to know that we're doing that great of a job already and need to maintain that performance, or figure out how we manage the easily preventable denials and not worry too much about the metric. Maybe that doesn't become one of our 2 to 4 key indicators for revenue cycle, and we have more opportunity in AR or point of service collection, something like that.
Yeah, that makes perfect sense. I feel like when we talk about data and using data and decision making and strategy, et cetera, some of the examples you provided I would say, are more performance indicators on what, like you said, whether it's production or efficiency in denial management or whatever it may be. But the other side to data and really all of these ultimately tie back to financial performance. And I feel like that's probably where a lot of our heads go when we hear about data-driven culture. And I know you talk about it in your presentation. So maybe talk to us for a minute about how financial performance plays into this data-driven approach.
Yeah, I mean, I think whether you're in a large academic medical center, a small private practice, a private equity-owned roll-up, or anything in between, large employed network or for a for-profit hospital, there are some fundamentals that measure the success, the financial success of the organization. And we like to use ratios to measure financial performance more so than gross totals, which I think is pretty common, but just want to state that because I think if all we do is track revenue, as an example, or even net income, our bottom line net income. That's really important, particularly at the private practice level, but it's not necessarily scaled to our growth or to changes in our practice. And so if we, for example, if we add 5 physicians to a 10 physician practice, then revenue should go way up. And maybe we see the same profit margin maintained, maybe we don't. And there are multiple ways to calculate that. But we like to look, when I say ratios, at, collections per work RVU, fee for service revenue per physician FTE. Again, both benchmarkable, and both, as you change and grow or contract over time, give you a sense of relative performance in those environments. Claim denial percentage is another one that it can fluctuate as you grow or bring on new and old, or shrink your provider network. Ultimately, having a bottom line measure for your group, whether that's an investment per physician FTE or net income, or revenue per physician FTE, that informs your bottom line financial performance, is important. And so we will often, in an employed physician network setting, working for a hospital system, use the investment per physician FTE as a metric of how the group is performing financially overall. That may be a product of payer mix. It might be a product of physician compensation design, or revenue cycle, or our expense management, from non-provider staffing to supplies, rent, all the other things that get lumped into that. But as we roll it all up to something bottom line, if I'm the CEO of the health system looking at the financial performance of my employed physician enterprise, then I want to know how much we're investing, spending, generating, or losing per physician FTE, and whether we grow from 100 to 200 or shrink from 100 to 50, I will still have that relative sense of our performance over time. And so boiling it all down to something that we can measure to and work towards at the executive level, but then that can also permeate all of these other smaller areas that our directors, administrators, practice managers, and even our physicians and frontline staff can help move the needle on. And so the impact, it's important for organizations to connect the dots between, this is our investment per physician FTE, but the reason is primarily because of our point of service collections, or because of our revenue cycle performance, our denial percentage. And so the way we're trying to improve our investment per physician is not the physicians seeing more patients, maybe, and generating more revenue, but better collecting the revenue we already generate, or better managing the expenses we already have in the house. And so understanding what you're working on in that regard is key and fundamental to any type of process and change, implementation of change in your organization.
Mm-hmm. Yeah, that's a good point that you started off with, because, looking at revenue or net income or any of those kind of single financial oriented metrics is, like you said, it's helpful, but it only kind of tells you what, I guess, when you break it down into more meaningful ratios and other metrics that get a little bit deeper, it tells you, at least points you, or can point you in the direction of why a little bit more. I mean, if you look at year over year revenue growth, it's like, okay, we're growing, but where and how and why, and is maybe a totally different thing. So when you really break it down, and once again, I want to reference the slides in your presentation, and encourage folks, if they're again interested, reach out to us for these, because you give a lot of really good examples around some of the different metrics that tie back to financial performance that groups can use. And, I think that's helpful to see in action, because I know data can be, it can be kind of a daunting thing sometimes, but once you get to that point where it's working for you, it can really tell you a lot about where you're doing well and where you need to improve. And there's some great examples of that you go through. One of the things I wanted to talk about also, and you reference in your presentation, is how does staffing play into this? The data that person in the call center, in your example, that they work with and see may be the same or may be different versus what the physician partners in the group see versus what the board sees, or if it's an employed group as part of a hospital, what that management team sees. But how does staffing play into this? And talk about some of the ways you approach that when you're trying to work on this type of initiative with a client.
Yeah, good question. So, staffing is a good example of how we use metrics that are important to the organization to drive individual performance at the staff level. And so just like we crosswalk data from patient access perspective, no shows, cancels, third next available, with performance data, how many work RVUs are generated by that location or by that group or by that physician, along with the no shows and cancellations. What's our slot utilization? What's patient satisfaction look like for those same groups? And we start to overlay these different data points, we get a much more accurate picture of where we have opportunities, where we have access issues, where we have productivity issues, where physician compensation and productivity are misaligned. And similarly for staffing, we start to see that we're using more resources in some locations to produce fewer work RVUs, as an example, or less resources in others to be our best performing location. When we're thinking about, so there's a difference in staff performance and managing your staffing levels. And coming out of COVID, there's a lot of concern around staffing, and it's less about how you manage your staff and more about where you find them, which is a very tough problem to solve, especially depending on the market that you're in. We have a lot of clients who are just struggling to find bodies to do the work that's needed, particularly on the clinical side. And so, one of our two different agendas with staffing are, one, to put incentives and metrics into staffing competencies by role that are part of performance reviews, and to the extent you have the ability to, financial incentives, where I know that in the call center, I'm responsible for phone stats and verification of insurance or demographic information. Or if I'm clinical, I know I'm responsible for starting chart notes and having certain quality metrics reported upon, and patient satisfaction or prescription refill turnaround time. If I'm in the billing office, I'm looking at a couple of metrics around days in AR or denial percentage and things like that should be easily trackable metrics that are not necessarily fully in the control of one person in the billing office to improve the denial rate. But if it's a group target of a 5% denial rate, and my manager can connect the dots for me as to how I play a role in helping with that denial rate and managing that denial rate, then that becomes your talking point for performance improvement. And so when we think about using your data and engaging your staff, getting them to collaborate on improving, that's really one of the core tenets of kind of our staffing utilization, staffing improvement. There's also this question of, do we have the right number of staff? And so staffing in and of itself, whether it's the staffing expense or the staffing levels, right, our FTEs by location, by provider, by division, however you track it with your organization, do we have the right number of people doing the right jobs in the right places? And answering that question is an analysis, but then how do you manage it ongoing is more of a position control process. And so if you use the same data and same targets for both, then it really gives you a lot of consistency and reliability when it comes to having those discussions. Hospitals have been doing this for years, but on the physician practice side, we often make a decision to hire a new phone representative or a new medical assistant because a physician one day said, I had a complaint from a patient that, they were on hold for 30 minutes. And so no one's answering the phones. We need another phone person. Or I came out and needed someone to get something from me in the clinical staff area, and there was no one there. And so we need more people. I got to have another nurse. And those types of staffing decisions have been getting made forever. And then that's how you end up with one provider having a scribe and two dedicated RNs and a dedicated phone line, and another having half an MA and rooming their own patients. And it's usually not quite that bad, but there's a lot of disparity when we go in terms of where we allocate resources. We also see groups that have overhired in one particular area to help supplement what they can't find or hire in another. An example might be hiring only MAs and having a call center full of medical assistants who can also help in the back office when people are out or when we have turnover, et cetera. Depending on your group size, I'm not necessarily opposed to a strategy like that. If you're helping to cross cover or kind of developing your own float pool, usually makes more sense in a smaller setting, but it needs to be done with intention. And so if you know you're going to heavily overweight yourself from a balance perspective with clinical staff, then make that your target. Even though the benchmark will always say you have more clinical staff than you need, if you know you're using clinical staff in a variety of roles and you're willing to pay a premium to have that expertise, then that's okay. Set your targets accordingly. And that can be your organizational staffing target. But we use what's called a staffing calculator with many of our clients to not necessarily to make a decision about whether to hire a new employee or not, but to at least give you some consistent backing to say, Dr. X, I realize that you want another medical assistant or think you need more resources, but you're producing at the 30th percentile and we can't justify additional resources for this based upon the generation, the productivity generation of this practice or of your location, et cetera. And this is an organizational standard. So if you feel like you're not able to produce the way you want because of certain reasons, and one of them may be staffing, let's work on our workflows and our efficiency versus throwing people at the problem. Because I can tell you already have more staff per work RVU than these locations or than everyone else, whatever it may be. So to be armed with that kind of data at your fingertips, and for someone who's coming to request a position, to bring that data to an executive team and say, here's why we need another person. I know doesn't look like it now, but we're bringing on a new provider next month, and then we're expanding to a second site and this location. So we're going to need this extra person. Then, okay, while the data doesn't screen for it today, we can make a rational business decision based upon the circumstances. And it just allows you to make more informed decisions. Mm-hmm. And it gives, again, parity and consistency. So I think that's, on the staffing side, how we try to work with clients to make staffing less subjective, and then also to make staff performance less subjective, where it's not just did so-and-so do a good job and have a good attitude, but did they meet their metrics? Did they answer 100 calls a day or 200 calls a day? What's the target for this call center? Mm-hmm. All those types of things can be really helpful, and actually quite the contrary to staff feeling like they're being micromanaged. It gives them something to work towards. They take ownership of that. They're engaged now in their own performance as opposed to hoping their manager is pleased with whatever they've done at the end of the day.
Mm-hmm. Yeah, that's a good example that you went through, because as we said earlier, the data helps provide a lot of additional context, but at the end of the day, data needs to be interpreted and validated as far as, once again, like maybe there's something else to the data that's not reflected in raw numbers or whatever, but like adding on an additional site or staff or whatever the case may be. But that's where the rational business decision comes in that you talked about. And I'm kind of bouncing around a little bit here, but I think it's part of the staffing discussion here. But earlier, when you were talking about some of those key principles or themes, you talked about the importance of accountability and ownership, as well as importance of teamwork. Where does that come in on, trying to improve those workflows and becoming more efficient and less redundant, and being more measurable?
Yeah, I think having everyone rowing the same direction is one of the key priorities here. And so, getting the staff engaged on and aligned on the same goals and objectives as leadership is step one, but you've also got to have physicians engaged in that. And so whether that's physician leadership because it's a private practice and our physicians are the owners and they're as much driving the strategic direction as anyone, or if we're in a large employed practice setting and physicians aren't really charged with a lot of administrative duties, but they're still the leaders in the hallways on a daily basis. And it's still, them with patient ownership and working, captaining the team in the clinic every day, and having their buy-in, support, and engagement, not just in what everyone else is doing, but in their own performance and in their own outcomes and how they impact revenue cycle, right? How their coding and documentation impacts everyone else's ability to generate a clean claim and get paid the right amount for that claim. And how they set a precedent for patient access and patient satisfaction based on how they interact with patients, how they make themselves available, how they manage their schedule, how they communicate with staff. And so the more we can engage physicians early on and not just achieving the outcomes that we're after, but being part of that solution. And it's not the office working around me, but the office working with me, both front, clinical, billing, and administration. That's where you're going to see the best results. And so when we go through these processes with clients, we really try to engage physicians from day one, whether they're physician owners or just physicians who joined the practice last week and are going to be part of the future performance of this group. Having a seat at the table, engaging them in a way that makes the most sense for their individual contribution. They could be the chief medical officer, or they could be, on the EHR conversion committee, or whatever it is, whatever their role is, and however they fit into the organization. Having physicians engaged and aligned with staff and administration is a key piece of the outcomes, and it really changes how much success you're able to achieve. And ultimately, when we're thinking about financial performance, physician productivity in most cases, unless you're in a heavily value-based reimbursement environment, is still going to be the biggest factor. What the revenue they generate and the compensation they're paid will be your biggest drivers of revenue and expense. And so making sure that they take ownership of their own data and outcomes, in addition to how they influence these other indicators that we've talked about, and staffing management and engagement and strategic objectives, will really ensure success in the long term. And it's hard to have as much traction as you want without it. And so we're pretty dogmatic about getting physicians engaged and having physician leadership when we go through these performance improvement processes.
Yeah. Well, that leadership is essential, and, which is no surprise to say, but I think sometimes it gets neglected for whatever reason, or it's just not prioritized. So I think that's a critical point there. And we've covered probably in, 30, 40 minutes, a very high level, once again, as I said earlier, a very high level discussion on this much deeper presentation that you have given. And, but it really is helpful to at least, start the discussion with this, I think, because a lot of organizations are either going through this or want to engage in something like this. Maybe they don't know where to start. This is a very helpful resource, or maybe you're already going down the road, but there needs to be some improvement made as it relates to a data-driven culture. So this is extremely helpful. I appreciate you taking at least a few minutes to talk about this with folks. And once again, I really encourage people to reach out to us, reach out to Brandt or myself, to have kind of a deeper discussion and maybe get into some more detail, because once again, there is a lot here. So I appreciate you talking about it. We'll look forward to continuing the conversation and look forward to talking to folks that may be interested in taking a deeper dive. So thanks, Brandt.
Thank you.
We hope you enjoyed that episode of Coffee with Coker, and we thank you for listening. We want to encourage all of our listeners to participate and contribute in the podcast. So if you have any questions on any of the things we discussed in this episode, any of the topics that were presented, please feel free to ask us. Also, we welcome your feedback and suggestions. If you have any ideas related to the material we discussed in this episode, or in any episode, please let us know and we'll make sure to incorporate it. And if you have ideas for topics you'd like to hear more information about in future episodes, please send those suggestions to us. We would love to hear them, and we'd love to incorporate them into our future episodes. You can find us online and on social media. Start with our website, and specifically the podcast is coffeewithcoker.com. You can also find that through the main Coker website at cokergroup.com. You can also find us on social media, Twitter at Coker Group, and then on LinkedIn, you can search for Coker Group and find our page and the page for some of our team members as well there. So you can find us and reach out to us in a number of places. And then if you want to contact us directly, one of the best ways to do that, email feedback@cokergroup.com. That's feedback@cokergroup.com. And again, we'd love to get your feedback. And we'd love to encourage everyone to subscribe to the podcast so that you can be notified when future episodes are released. We look forward to the next episode, and we look forward to getting your suggestions and feedback on this episode. Thanks for listening, and we look forward to speaking with you again on future episodes.